Good afternoon, TechNation. Welcome to Webinar Wednesday. We are excited to have over 200 registered attendees for today's webinar, which is eligible for 0.1 CE credits from the ACI. A housekeeping note before we begin, please make sure you download the workbook, which is available in the Handouts tab of your dashboard, as there are several very detailed slides in today's presentation. This will ensure that you can read them properly. Let's go ahead and get started by giving one lucky attendee a TechNation t-shirt for answering this trivia question. Who was the famous Lambeau field named after? Answer now using the questions feature on your dashboard. While you are answering, I want to remind everyone to mark your calendars for MD Expo Irvine, April 9th through the 11th, 2017. To receive more information about this and other upcoming MD Expos, including the educational lineup, schedule, and special events, sign up for our newsletter at mdexposhow.com/Irvine. All right, and the winner of the TechNation t-shirt is Michael Smith. Congratulations, Michael. The correct answer is Curly Lambeau. TechNation would like to thank our sponsor, Technical Prospects. Technical Prospects is your only alternative to new, pre-owned, and refurbished Siemens medical imaging parts. Also, they offer engineer training on your Siemens medical imaging equipment and technical support on your parts purchases. Technical Prospects is your partner at every stage. Visit technicalprospects.com to learn more. Our presenter today is John D. Pasquale, Technical Trainer for Technical Prospects. John, you may begin whenever you are ready.
Thank you. Welcome, TechNation, to Mammography and MQSA, an overview. First off, before we begin, let me talk a little bit about myself to give you some of my background. I originally got my start in electronics in the U.S. Air Force, where I served as an aircraft electrician for 4 years and then as a biomedical equipment technician for the next 18 years. There I worked as both technician, manager, instructor, and also finished my career as a regional manager. After my military service, I spent 8 years in various imaging and biomedical capacities, including asset management for both in-house and third-party contract positions. I left the industry in 2000 to teach high school mathematics in the Connecticut Vocational Tech System. And after about 6 to 7 years of that, I came back to the industry that I loved. I had my first OEM experience with Hologic, where I served there as their technical trainer on both analog and digital imaging systems and support system for their mammography lines. In early of 2013, I moved to Wisconsin and began my career here at Technical Prospects in December of that year. My background includes a master's degree in education, a bachelor's degree in electronics engineering and business administration, 2 Associate of Applied Science degrees, and instructor in biomedical equipment technologies. I have been a ICCC vet since 1994, and I was certified as a master instructor in the Air Force. Anyway, that's enough about me. Let's get into what we wanted to talk about, the hard question. What is MQSA? Well, a possible answer, it is the United States supplemental law for establishing the requirements for the mammography modality. In addition to 20 CFR Part 1020 Subchapter J, which governs oversight for radiation-emitting products, it establishes the additional specific guidance for accrediting bodies, mammography facilities, equipment, both analog and digital, personnel, radiation dosage, patient notification, record keeping, and quality control for this modality. Additional note here for you is I'm going to be specifically speaking about the United States law. However, you should be aware that our law here in the United States is closely aligned with that of the international community, and while there may be some differences, please consult your country's regulations for the specific that applies to you. A quick disclaimer, I'm only here to familiarize you with the law and give you an overview. For the exact specific documentation regarding this, go to the actual website. You'll see it here highlighted for you, or you can just Google MQSA and the top item will take you to this link. So what are we going to talk about today? Well, let's give you a little bit of an overview. We'll get specifically into the MQSA requirements. We'll talk about some personnel responsibilities, get into some terminology, and lastly, some digital equipment. So let's get started. Right here with the overview, we're going to break this down into 4 key areas. Key terms, the preface, the introduction, and also some background information. Some key terms are actually some acronyms that you're going to be experiencing, such as ACR, the American College of Radiology, the FDA, which is the Food and Drug Administration, HHS, Health and Human Services, and a couple others that you should be aware of, such as CFR, the Code of Federal Regulations, and AART, the American Registry of Radiologic Technologists. Now, as we go through this, there are questions we're going to try to answer today, so keep them in mind as we go through. One of our questions is, what is the MQSA? Another is, when does MQSA apply? Where does it apply? Why does it apply? Who is MQSA? And lastly, how does it apply? So with these in mind, let's jump right in. Who is MQSA? Basically, it's the federal government of the United States. It is public law that is enforced by the FDA, but policed by Health and Human Services, or HHS. What is MQSA? MQSA is the Mammography Quality Standards Act that became public law in October of 1992. By its definition, MQSA is the FDA program that certifies mammography centers meet the following quality standards for personnel, equipment, radiation dosage, patient notification, and record keeping. Now, why did all this come about? Well, let's look at some background. Basically, breast cancer is the leading form of cancer amongst women. As a little comparison for you, and during the 10 years of the Vietnam War, where 57,000 soldiers died, 330,000 women died from breast cancer. Now, all this here got its start way back when in 1913 when a German surgeon, Dr. Solomon, conducted studies and stuff and began looking at breast cancer itself and the characteristics of the invasive carcinoma. However, the world got in the way of these studies and everything, because in 50 years very little was done during that time. And that was because of the world wars and just the different things going on in society. However, as things began settling down in the 1960s, Dr. Robert Egan developed a direct film mammography technique whose key factors were a generator capable of producing 20 to 32 kV, which is low for an RF system, at least 1800 mass. A cylinder or D cone was used as the collimator to restrict the field. The film was a fine-grained, slow-speed film requiring an 8-minute hand processing cycle. And there were 3 views used for complete coverage. However, the diagnostic accuracy was 97%. Well, since these early studies, we've had significant advancements in both film and film processing and the equipment as well. Smaller doses of radiation are now due in part to the advancement. Different types of anode materials, different filters, smaller focal spots, compression devices, and dedicated processors for film, film speeds, and film screen combinations. A quick example of some of these improvements, just looking at the entrance skin dose. 8.3 Rankins before 1970. Now, 0.4 to 0.6 Rankins post 1984. Significant reduction in the amount of radiation given to our patients. The most significant factor, however, was Public Law 102-539 in October of 1992, as it established the MQSA. This law defined the federal regulatory requirements for mammography. The passing of this public law empowered the Health and Human Services by providing strength, credibility, and oversight of the mammography programs, while forbidding any person, business, or practice from engaging in a mammography program without certification. From 1992 to 1994, MQSA approval could only be granted at the state level after the state's mammography program was approved by the federal government. During this time, there was also a gracing period, but after 1994, every mammography facility had to be certified. Okay, the law has been recertified in 1999 and 2004 and remains in effect today. So when does MQSA apply? Under MQSA and after October 1st of 1994, all mammography facilities, whether in a hospital, doctor's office, mobile van, military base, or any other public or private enterprise, must be accredited and federally certified as meeting these standards. They're subject to federal inspection and certification, and after initial certification, must pass annual inspections by approved federal or state inspectors. Now, these not necessarily have to be on site. They can also be just submitting information to or self-reporting. Where does it apply? All mammography facilities across the United States, its territories, the Commonwealths are now required to operate under this law. The only exemption from the law is Veterans Administration hospitals. However, they have stated that they will comply with all requirements of the law. Why does this apply? In the most simple of terms, is to improve the quality and delivery of the mammography to the patient. How? Well, that's what we're going to be discussing here as we go through the requirements. And as the requirements, let's take a look at what we're going to cover here. You can see a full list of different things from the accrediting body, facility, personnel, equipment, radiation dosage, patient notification, record keeping, and also quality control. For the accrediting body, basically the FDA or its representative group that notifies the FDA or certifying state after it's been determined that the initial facility accreditation application is acceptable or when the facility has been accredited. The FDA or certifying state issues an appropriate certificate. If they're fully certified, they will get a 3-year certificate and they must recertify before it expires. If there's some discrepancies, they will be given a 6-month provisional, and then they have to correct any deficiencies that exist. The accrediting bodies, the biggest one is the ACR. They cover all over the United States. However, 3 states, Arkansas, Iowa, and Texas, have their own state accreditation facility that also satisfies this requirement. In the state, they can only work within their state. However, they can also have additional requirements which also must be met should they reside in those states. What are the requirements? Facilities, standards review, a clinical image review, a physics survey review, on-site visits, complaint reporting process, reporting and record keeping, and also the fees that they're charged. So with these requirements here, let's take a look at each of these. Starting with the facility. Legislation has called for the mammography facilities to be accredited, certified, and inspected, and they must demonstrate a system of checks and balances. For example, the following annual updates must be provided, and this is self-reporting. Any personnel changes, equipment changes, their quality control logs, and also the annual medical physicist report. When we say who is affected, well, basically we're looking at the interpreting physician or radiologist, the medical physicist, and the radiologic technologist. Notice us field engineers are not part of this. We will address this later as to why. What must we comply with? Initial qualifications, continuing education, continuing experience, and reestablishing qualifications. As we look at each of these under the personnel groups, we'll start with the interpreting physician or radiologist. If their initial qualifications, as you can see, are extensive. They have to be licensed and board certified or have 3 months training in interpretation, radiation, physics, effects, and protection. 60 hours must be in mammography with 15 hours within 3 years prior to meeting the initial requirements. A certain amount of minimum mammograms, such as 240, and they have to have 8 hours of training in any new modality before use. Now, this is what any new physician coming in complies with. There were some exceptions which out to the initial qualifications, but this was predominantly back in 1992 when the law first came into effect is when these initial exemptions applied, so you can see what they are listed here. Moving on from here, we have the medical physicist who also has their initial qualifications, and their role is to certify on behalf of the facility the work that we do. Okay, so they have to be certified. They have to have a master's degree or higher in a physical science, 20 semester hours of physics, 20 contact hours of training in conducting surveys for mammography, have surveyed at least 10 systems, and have 8 hours of training in any new modality before being able to do surveys. Again, the alternate qualifications existed predominantly way back on the initial. However, there are some factors that they can still qualify today using these alternate certifications. The radiologic technologist also has theirs. They have to be certified by AART or ARCT or have state licensing in general radiology. They have to have 40 hours of training in breast anatomy, physiology, positioning, compression and QA/QC techniques, imaging of patients with implants. They have to have completed at least 25 mammography examinations under supervision and also 8 hours of training under new modality. Again, there was an exception to their initial qualifications under interim rules, and as you can see, the requirements are listed there. Now, that's just some background information for you. The area where most of us need to be focusing here on is the equipment. So as we look at the equipment certifications, we're going to get more detail into here. The equipment here must be specifically designed for mammography and dedicated to this use only. It also must be certified according to the CFR, Section 1020 Part 3 and 1020 Part 31 as of the date of manufacture. Now, as we get into some of these certifications, we're going to look at the specifics here. The first one is motion of the tube on the image receptor assembly. The unit must not have any unintended motion once fixed in a position and shall not fail in the event of a power failure. The image receptor must be capable of providing 18 by 24 or 24 by 30 at a minimum. They can have more than this. For systems using screen film image receptors, they shall also be equipped with moving grids to all of the image receptor sizes provided. However, mag tables, you cannot have a moving grid in the operation, so it is removed from there. The light field has a minimum lux requirement of 160 or 15 candles at 100 centimeters or a smaller SID, whichever is less. This is part of the reason why it took a long time for the mammography world to go to the LED lamps, which are now starting to appear in the equipment as opposed to the standard halogen lamp. Magnification is also has some ground rules here that they must be able to provide this for interventional problem solving. This is not screening. This is when they come back for various imaging procedures. The other thing is if they use magnification, it must be between 1.4 and 2.0. Some manufacturers use a fixed value, others will have an adjustable stand. Focal spot selection. When there's more than one focal spot provided, the system shall indicate prior to exposure which one they're using. When more than one target material is provided, that also needs to be indicated. And when the target material and or focal spot is selected by a system algorithm based on the exposure or on a test exposure, the system must display after the exposure which target and or focal spot was actually used. When we look at the technique factor in display, manual selection of mass, which is milliamperes times time in seconds, or at least one of its components must be available, MA or time. The technique factors shall be indicated before the exposure begins, except when automatic exposure control, AEC, is used, in which case the settings prior to the exposure shall be indicated. Following AEC, though, the system shall indicate the actual values for kV, MA, time, or mass. When we look at compression here, all mammography devices shall incorporate a compression device, and after October 28th of 2002, this needed to be an initial power-driven compression that's activated by hands-free controls and have a fine adjustment on either side of the patient. Our compression paddles, they will have different sizes available for different types of imaging. The compression paddle needs to be flat and parallel to the breast support table and shall not deflect from parallel by more than 1 centimeter at any point when compression is applied. Equipment that is intended by manufacturer to not be flat and parallel to the table during compression shall meet the manufacturer's design specification and maintenance requirements. These are for different flex paddles that are out there. The chest wall shall be straight and parallel, and the chest wall edge may be bent upward to allow for patient comfort, but should not appear on the image. When we look at AEC, or automatic exposure control, each screen film system shall provide an AEC mode that is operable in all combinations of equipment configuration provided, such as grid, non-grid, magnification, non-magnification, and various target filter combinations. The unit needs to have multiple selectable detectors, which must be clearly indicated on the surface of the compression paddle of which one is also which one is being used for the exposure. Those are the little indicators on the paddle, and you'll see any typical numbers 1 to 7 different positions. The operator must be able to vary the selected optical density from the normal. Basically, where we do is we calibrate the AEC in the normal mode, and this is how they can lighten or darken the exposure through the density control. When we're in mobile settings, a physician need not be present for the screening to take place, which is the 4 X-rays. However, the films will be batch processed and then referred for reading once they return to the facility. There must be strict adherence to documented protocols. For example, one of the things is phantom shots must be successfully accomplished after each relocation of the mobile unit. That is to ensure that the unit is operating and that that shot is developed to ensure that the quality of the mammograms for the patient is maintained. When we look at X-ray film, the facility must use film specifically designed as appropriate for mammography. All films must be kept and accounted for, mammograms, both good and bad, and all your maintenance films. And these film records for 5 years. When we look at the intensifying screens, the facility must use screens that are appropriate for mammography. The film used must match the spectral output of the screens as specified by the manufacturer. What this means is that the screen speed and the film speed should be in an appropriate range for one another. When we look at film processing here, the chemicals used must meet or exceed the minimum requirements for processing as specified by the film's manufacturer. When viewing films, the lighting for the special lights for film illumination must be provided for the interpreting physicians, which is brighter than the standard illumination provided by the view box. They also have to have hot lights available. And film masking devices must also be available for the interpreting physician so they can limit the area to a smaller portion. When we look at radiation output, the conditions for measuring, we have to use a standard mammography mode. We can use any source to image distance, but generally that is fixed. However, it must be measured 4.5 centimeters above the breast support surface, and the compression paddle must be in place between the source and the detector. The minimum average output over a 3-second period, well, prior to 2002 was 513 milliroentgens per second at 28 kV. Now we're shooting at a minimum 800 milliroentgens per second at 28 kV. We use the word average in the event of pulsed outputs. When we look at radiation dose, we're talking glandular dose, and this must be certified annually by the physicist. The conditions here for this is you're using a 4.2 centimeter 50-50 compressed breast equivalent phantom material, or BR12 or Persipex or acrylic, consisting of 50% glandular and 50% adipose tissue at 28 kV. The previous requirement from October 28th of 2002 was that the glandular dose would be less than 513 milliroentgens per second at 28 kV. The new requirements now, since that time, are 300 milliroentgens per second at 26 kV, which is the FDA standard nationwide, except in Michigan and Oregon and some international communities where it is now at 200 milliroentgens per second. Patient notification is a very, very important factor of the law, and it states that the FDA believes that the quality, if they believe it's been compromised, they will have to notify the patient that the images were not of good quality. And if the FDA determines that, they will give them a time frame where this must be complied with. Failure to do so can result in shutting down of the facilities. Now, one thing I should mention at this point is that any types of notifications from the FDA, all of this is published on their website for public information. So this makes everyone aware of what's happening with these facilities. Here in the record keeping, there are certain requirements here. As you can see, it's a very detailed slide. This is something that I would refer you to your individual handouts to look over the different requirements here. The key thing here is that each facility shall send the patient a summary of the report within 30 days of the mammographic examination. If the ones are suspicious or highly suggestive of malignancy, they like to get those out even sooner. Communication with the patient or their healthcare provider, we need to get the information again out as quickly as possible. It's critical that the patient be notified, but if they've given the name of the provider, their provider also must be notified. Record keeping is a major factor here. For reoccurring personnel or patients, let me rephrase that, records have to be kept for at least 5 years. However, if a patient comes to a facility and then begins moving on to another facility for their mammograms, those mammograms must be kept for 10 years. Image identification, there are certain requirements here. That are all there that have to be as part of this on each image. And a consumer complaint mechanism shall be established. What are the requirements if they have complaints? And this is all has to be documented for not only the patient, but also as part of their annual reports and stuff. When we look at quality control, let's look at these assurance records. All right. For example, we're going to look at personnel responsible. What are the requirements of the physician, the technologist, and the medical physicist? We're going to look at the different types of records. And you see a list of these factors here. And we're also going to take a look at the time frame and compliance. So with this over here, when looking at equipment, we have got daily checks that must be accomplished before any clinical procedures are performed. Film processors, the operating levels tailored for that facility. You've got certain tolerances. So if you're still using film and wet screen processing, these are things that have to be documented every day. And for us as field engineers, this is a good place to look if we're having image quality issues, because if there's been a change in deviation from the baselines, there's a good chance it may be the processor rather than the equipment. There are certain weekly checks that the facilities must do, and this requires the use of an FDA-approved phantom. Some of the tests that are performed, they have to have the optical density of the image, which is going to be greater than or equal to 1.2 at the image center. The density obtained must be within plus or minus 0.2 of the operating level. They have to have a minimum score for the fibers, masses, and specs. and the background density shall not deviate more than 0.05 from the operating level. When we look at our quality checks, now we're looking at quarterly checks, we're looking at fixer retention on film, and also repeat analysis. How consistent are we? Why it happened? Are there any corrective measures? And what was the effectiveness of these corrective measures? Semi-annual checks include darkroom fog, screen film contact. This requires a 40 mesh copper screen and is used on all cassettes in the facility, must be tested. This is to ensure that good contact for accurate image transfer. And also the compression device, a minimum force at 111 newtons or 25 pounds, and initial power compression shall be between the 25 and 45 pounds or 111 newtons and 200 newtons. Quality assurance, also our annual checks as we continue on. Automatic exposure control, KV accuracy and reproducibility, focal spot, system resolution and dimensions. Beam quality, half value layer, because every X-ray changes the effectiveness of our tube. The Brent's entrance dose or absorbed dose is checked, AEC reproducibility, and lastly dosimetry. Also checked is the X-ray field to light field, the image receptor, compression paddle alignment, uniformity of screen speed, your system artifacts, are there any? Radiation output, and it must be measured at 4.5 centimeters above the breastplate. However, a little key tip here for you. Look at where the sensor is inside the actual detector. That's what needs to be set at 4.5 centimeters because that's what establishes equality between the different types of detectors that are out there. These checks that we're looking for are greater than to equal to 800 milliroentgens per second, which is 7.0 milligrays air Kerma per second at 28 kV. And last thing, do we have a decompression at the end of the X-ray in both manual and automatic modes? And also in terms of this, other modalities, this is going to apply to other systems other than film screen. They should be substantially the same and they may not exceed the maximum allowable dose established for film screen systems. Mobile units, they've got to be tested at each location before doing clinical exams, and the testing method should establish the adequacy of the image quality produced. Test results, we're going to compare to previous results or manufacturer standards for compliance and deviation. If the previous discussed tests are outside the allowable limits, the system is shut down and no further exams can be done until the problem is identified and corrected. Key thing here for us as field engineers, this may require a physicist involvement and recertification. Other deficiencies can be corrected within 30 days, but anything involving image quality must be corrected immediately. When we look at these surveys, they are required annually by the medical physicists. Their performance testing, and we just gave you a list of all of the things that are being done. They will also be examining the weekly phantom image quality testing as done by the operators. The medical physicist is responsible for determining the adequacy of all testing, corrective actions, and the results. And his written report must be done within 30 days. It contains a summary of findings and recommendations for necessary improvements. This is why it's important, and my personal recommendation, that you are there when the physicist is performing the inspection, so one, you can see what they're doing, but two, you're there to correct any deficiencies. Now, when we look at this, the mammography equipment evaluations, it requires that they be certified by the physicist or the representative for a new installation, for a used equipment installation, or if the system is relocated. Equipment may not be used for clinical exams until passed by the physicist. Another factor of quality control is facility cleanliness. The facility shall establish and implement adequate protocols for maintaining darkroom, screen, and view box cleanliness. Facilities shall also document all cleaning procedures that are performed and the frequency for the specified protocols. And the calibration, medical physicists, their equipment must be calibrated every 2 years, or if repaired. Calibration must also be traceable back to a national standard and have a plus or minus 6% accuracy within the mammography range. Because we're dealing in our world here with the human facilities, we also have to have infection control procedures, and they must also be for cleaning the equipment as well as for any contact with blood or any potentially infectious materials. The documentation for this documentation will also have facility compliance with federal, state, and local regulations, with the manufacturer's recommendations for cleaning and disinfecting the equipment, or comply with generally accepted until these are made available. The medical outcomes audit. They have to have a program for reviewing all positive mammograms and to correlate pathology results with the physician findings. They are designed to ensure reliability, clarity, and accuracy of the diagnosis. The audit frequency is 12 months for the program and also for the interpreting physician. The general guidelines review of all mammograms performed with follow-ups on positive mammograms and the correlating pathology results. If the patient who is examined by the facility subsequently is diagnosed with breast cancer, they shall have all data reviewed prior to the diagnosing of the malignancy. This is to ensure that nothing was missed. Moving on to our personnel responsibilities, we're going to focus on the physician, the physicist, and the technologist. Basically, they must be state certified to work in mammography. Again, notice the service engineer does not have to be. Again, we will get this into a little greater detail at the end. They must be part of an active continuing education program in order to maintain their certification. Now, the interpreting physician, he has a lot of different responsibilities. He has to ensure that the technologists that work for him have adequate training and also continuing education program. They have to provide for orientation for the technologists. They have to ensure that there's an effective QC program that exists for all mammography, and the radiologist will provide the oversight, the motivation, and direction of the program. He will also select a primary and alternate person to ensure that these tests are done. He has to ensure that all the appropriate test equipment and materials are available for testing, arrange for staffing and scheduling so that adequate time is available to carry out these tests, and to record and interpret the data. He has to be able to provide feedback to the technologist, and he also is responsible for selecting the medical physicist who will oversee the equipment related QC program and perform the tests. Other factors here is conduct a periodic review of the technologist tests every 3 months and annually for the physicist. Appoint a contact to oversee the radiation protection program for the employees, the patients, and other materials. This is why they have the badges and stuff, to ensure that these are all current and what's going on. The Quality Assurance Procedures Manual must remain current and updated and must contain the following information: employee records of their qualifications, mammography techniques and procedures, infection control procedures, QC procedures and guidelines, safety procedures. Basically, this is an open book test. This is what this whole thing is all about, these manuals, and are they doing what they say they are doing. All mammography physicians must follow the facility's protocol when asked to interpret images of poor quality, participate in the medical outcomes audit, and provide documentation of their current qualifications for the mammography facility where they practice. Moving on to the medical physicist, their performance testing is broken down into 3 major areas: image quality, dose evaluations for the patient, and operator safety concerns. And they must perform an annual performance test, and it must be documented. The areas testing are what we've been talking about: the mammography unit assembly evaluation, collimation assessment, system resolution, AEC, uniform screen speed, artifact evaluation, image quality, reliability and accuracy of the KVP, beam quality assessment, half-value layer measurements, beam entrance exposure, AEC reproducibility, average glandular dose, radiation output, and lastly the view box and room luminance for the film screen. With the exception of image quality and average glandular dose, which must be corrected immediately, all of the corrections to the physicist's findings can be corrected within 30 days. By immediate, if the issue cannot be resolved, the system will be shut down until the issue is resolved to the satisfaction of the medical physicist. This is why I recommended that you're there during the medical physicist inspection so that you can correct anything that he deems an immediate, that requires immediate attention. Otherwise, if the physicist leaves, he has to be brought back in after your work before they can use the equipment on patients. Whenever a major component of the system is changed or if the unit is reassembled after being dismantled, they must be notified and perform the appropriate testing to ensure the image quality has been maintained. Unit cannot be used on patients until the physicist certifies it. Now, generally speaking, what this means is back in the days we talked about certified components. Here in the U.S. now they've gone away from this term and we are now identifying which components by tags on these components, and they'll be identified as the CFR Part 1020 Subchapter J. Some examples of these are collimator assembly, the X-ray tube, AEC detectors, and so on. In terms of the X-ray technologist or radiology technologist, their primary concern is patient care and image quality. What does this include? Proper patient positioning, proper amount of compression, image production, film handling and processing, and infection control. They also are responsible for various levels of the QC test, the daily, the weekly, the monthly, quarterly, and semi-annual checks that are required under the QC program. Moving on into our terminology, we're going to look at this under three things: clinical, medical physicist, and also the equipment. From clinical here, you have a list of different terms here that you'll see on the different exams and stuff. You can read this as easy as I can present these here to you. And again, these are terminology that's used in the clinical environment. FEs, little suggestion, learn these terms so that you understand what the technologist is talking about. Moving on, your primary mammogram positions, there's two, the medial lateral oblique and a cranial caudal, which is your vertical shot. All right, these are the two required primary views for the screening. 2 exposures of each breast for a total of 4 exposures. Another key factor on the screening is they all must be done with the large filament. Some common tissue types: glandular, which is your muscular, your adipose, which is your fatty, and your fibrous, which is your connective tissue with high concentrations. Some other positioning and view terms that you'll see and labeled, you can read these right over here on the slide at your convenience. Moving on here, some specialized terms for the medical physicist, and some of these we will recognize, are material and dose, such as BEM, which is breast equivalent material, KERMA, which is the alternate term for absorbed dose, AGD, average glandular dose, EGD, entrance or effective dose, and mean glandular dose, MGD. You'll also see Rankins, millirankins, Grays, milligrays, and 1 milligray, which is the conversion of approximately 100 millirankins. Some test tools and stuff. They have both invasive and non-invasive means of testing. Invasive is a term that's used to describe a test result that is required directly from the source. An example would be connecting a high voltage divider to the generator to test KV. That is an invasive term. Non-invasive is now more accepted throughout the term, and this can be used as getting KV from the KV, measuring KV from the actual X-ray beam itself. The Phantom or BEM, this is a test tool that simulates specific breast tissue equivalents used for establishing an anticipated results when conducting dose or resolution testing. The most common here is a 50-50. They exist in others, but the most common one you'll find out there is a 50-50 of glandular to adipose requirement. When we look at the equipment, other associated terms should be very familiar here to you, the service engineer, such as KV, KVP, MA, HVL, Lux, SID, Grid, and so on down the line. Some terms that are unique to our world here: Mo, which is molybdenum, W for tungsten, RH for rhodium, AG for silver, CU for copper, and AL for aluminum. And you can see where they're used. These are terms that we should be very familiar with. Moving on into our last area here of digital equipment, we're going to look at two specific areas: the alternate rule and also the mammography system QC manual. As you can see here, as we went through MQSA, the regulation dealt predominantly with screen film or wet film processing. However, as we all know, today most of our equipment that's out there is digital. And what the FDA did is they created a set of alternate rules for compliance prior to use as a standard. Now, that doesn't mean we're not complying with the same things. It's just that we have different ways of doing it, as we are no longer using film screen images. We are now using digital images. On mammography equipment, this is the accompanying QC manual for the digital system. This comes with all new systems and it becomes law. All right? Digital equipment must meet the requirements. All right? For example, reproducibility testing. In the analog world, we used 10 exposures. And what we measured was the optical density that was obtained after processing, because that was our final end result. Here in our digital world, some manufacturers use 3, others may use 5. But what we're looking at now is the dose that is produced in generating the image, because when we get to our final factor, the interpreting physician has the ability to manipulate that image. The QC manual, the FDA requires its approval of the QC manual for digital systems, because the instructions therein are now a regulatory requirement. Why? Because the FDA has approved that manual. That means no one is allowed to deviate from it. The OEM digital equipment, digital mammography equipment will come with the approved QC manual. It must be followed and complied with. Now, if there's a difference between the general law and the specific requirements of the OEM or original equipment manufacturer's QC manual, the QC manual takes precedence. Something that's just happened earlier this year that you may not be aware of. There's a new alternate rule, number 24, that is effective as of March 7th of this year, and that is a facility option. The ACR Digital Mammography Quality Control Manual for full field digital mammography systems may be used on, with or without the advanced imaging capabilities, i.e. 3D tomosynthesis and contrast enhancement. All right? And what we're dealing with here is how they're allowing us to do certain things. Now, the contrast enhancement is advanced. We expect these rules here to change going into the future, so this is something that you should be aware of. However, this new alternate rule also requires the new full field digital mammography QC Phantom. All right? This newer Phantom covers the entire image receptor as opposed to the small one we used in the film world. At presently, there's only 2 manufacturers that are approved to produce this Phantom. You can find additional information as indicated on the website. An example of what this new Phantom looks like is shown right here on this slide. Also, that I also presented here for you is the new scoring mechanism, what it's going to look like and how to score for both a full point and half point for the fibers, the spec groups, and the masses. And something that's brand spanking new and hot off the presses, as I just came across this, is something called Equipped, which is enhancing quality using the inspection program. This was introduced last month on October 27th. It goes into effect this coming January 1st. There will be a 1-year grace period with these new laws and stuff, that no citations will be issued. However, there will be write-ups based on these new requirements. This is to ensure that a year from now that the facility will be now able to meet these new requirements. Basically what they did is they added 3 new questions and deleted 2 others, but the 2 that were deleted will still be applied within the law in other indirect applications. The new questions are designed to help meet the Practice Quality Improvement, PQI, of the American Board of Radiology for certified interpreting physicians who are subject to PQI requirements. What are these newly added questions? They're right here as indicated here for you. Do the facility's procedures ensure that the clinical images continue to comply with the AB standards and include regular reviews of sample images from each technologist and interpreting physician? Another question is, will access for corrective procedures when clinical images of poor quality include a feedback mechanism for the technologist and other personnel? And also access to the procedures for the local interpreting physician oversight of the QA and QC records to include the frequency of performance of all the required tests and determining whether the corrective action was taken when needed. So, what did we cover today? We gave you a little bit of an overview. We talked about the MQSA requirements. We talked about personnel responsibilities. We got into the terminology, and lastly we covered the digital equipment, how it applies under the law, and also some new and breaking factors as we look at the world of mammography. And that concludes today's presentation on MQSA and mammography, an overview.
Thank you so much, John. As we are coming up to the hour, I will just ask you a couple of questions. The first question we have got is, how often must the facility have the physicist come in and certify the mammography system? And if not done, what are the ramifications?
Okay, they must be conducted annually. If this is not accomplished and documented, the facility will be unable to perform mammograms until this deficiency is corrected. It will also be published on the website that they are no longer able to perform mammograms until corrected.
Okay. Of all the personnel involved with the mammography systems, why are the service personnel not included in the regulations?
Basically, service personnel are not part of the program, as they are not directly under the lead radiologist control. Because as field engineers, they can be OEM personnel, they can be third-party personnel, or they can be local in-house personnel but assigned to the biomedical or repair department. However, changes are taking place in some states that require field engineers to pass a state test prior to servicing any imaging equipment, of which mammography is a part of. In addition to this, there are certain facilities that are now requiring service personnel to have a diploma that certifies them to service the equipment by manufacturer and model, saying that they have been trained on this equipment.
Okay, thank you, John, and thank you again to today's sponsors, Technical Prospects. One lucky attendee will win lunch for their whole department. Details are included in the post-webinar survey, which will appear on your screen shortly. You must complete the survey to obtain your certificate of attendance. If you do not receive the survey, please email us at webinar@mdpublishing.com.